we all are having, like sarcopenia and COPD. Over to you, sir.
Thank you for that very kind introduction. A big thanks to IAPS, big thanks to Pritima, sir, and for all of you to be present over here to discuss sarcopenia. Just last week in one of our major online webinar series in respiratory medicine, we had a big webinar on sarcopenia. So this is now said to be one of the newest for us. It might be very common for you when you deal with diet, muscle, protein all the time. To be included in one of the multi-system effects of COPD, because like ma'am very well illustrated, the different conditions in which sarcopenia was there. Everything was there: sepsis, COPD, liver failure, all of the different conditions. COPD is one such condition which is reverse. Lung is in the middle, but you have practically every organ of the body which is involved. And the problem in COPD is that it is the respiratory muscle pump which is at fault. And the very basis of the respiratory muscle pump is your muscle. So having a problem in the muscle is bad enough, but then having that tadka of inflammation in it is worse. So sarcopenia is a problem which can be controlled by a group effort between you and me. When the pulmonologist with the dietitian works in tandem, then only while I take care of the inflammation, you only can take care of the particular pathology which is protein deficiency. So that is the gist of it. Means even if I don't present it, that is what it is. Rest, most of the things will be a repetition of what we have discussed already. But the important thing is again, which is dedicated teamwork. Not only ICU, but I would say, even COPD patients in the ward, they are also very tough to manage. And it's not a joke. All of the things which are highlighted in the presentation before, they are all those aspects which your COPD patients actually suffer from. And if, God forbid, you have any COPD patient who is related to you, you can understand the agony that they go through, and even their families, because it is a tale of repeated admissions, readmissions, going to the doctor again and again, seasons like this, and Indore is now facing seasons like this for the past 6 months. So we have to be very sympathetic, but at the same time we have to be very careful when we are dealing with advanced COPD patients. So my previous speakers have very well illustrated as to what sarcopenia is and what sarcopenia deals with. My job is mostly to correlate it with COPD. COPD is, in very common words related to sarcopenia, very, very heavily. There is a gross reduction in skeletal muscle mass, strength and function, which functions lung function and mobility. Prevalence is as high as 60%, forget the 15%. I would really put it as 60% looking at my own patients. And this particular photograph actually illustrates a very sad story. If you actually look at a 70 or an 80-year-old person who has smoked bidi or cigarette throughout his life, and you just have a look at it from in the OPD, you will see that this person is not healthy whatsoever. He is very weak, he is breathing so heavily, and for crossing from here to the gate, that person might take as much as 10 minutes, which you will do in 1 minute. So he is not able to do his walking properly. What will he do is breathing properly. It becomes very difficult. So this topic is very important. What COPD is basically, COPD is like a furnace. The lung keeps on emitting inflammatory mediators. Ma'am mentioned TNF alpha, IL-6. They are the biggest enemies, because once that process starts and your body keeps on releasing TNF alpha and IL-6, they keep on promoting catabolism in each and every part of the body. In order to control the TNF alpha and IL-6, you have to work at 2 levels. We have to control the COPD. आपका COPD control नहीं होगा तो इनका production बंद नहीं होगा. But till that happens, you will have to supplement it in a more than adequate fashion. That is what is needed in COPD. So it is very common I would just like to concentrate on the higher part, be it 40%, 25%, but believe me, nutritional issues in COPD patients are very important. It can vary from people to people. Like what I might have seen in a medical college setting, in a tertiary care hospital setting or a corporate hospital, you see almost a similar picture, but I would still like to quote that nearly 25 to 30% of our COPD patients badly need your help. And I know it is our fraternity as pulmonologists at fault कि हम नहीं बेचते. We can, you know, lot of these guys come to us और हम ही लिख देते हैं भाई तू 2 चम्मच ले लेना, 1 चम्मच ले लेना, पानी में ले लेना, दूध में ले लेना, वो सब करा करते हैं. But actually whenever I come to this meeting I realize our own folly. We should take your help in practically every COPD case that comes to us. That is important. Second thing is COPD, you know, when I joined 20 years back, sir, when I was a student in MY, I have patients of mine still coming to me. It's been around 23 years. But वो जुड़ जाते हैं और इंदौर वाले जुड़ जाते हैं तो छोड़ते भी नहीं सर. तो वो ढूंढते ढूंढते आ जाते हैं. When they come, you see picture of people who were relatively healthy. बस बीड़ी पीता था, खांसता था. अब आप देखते हो कि अब उसके लड़के को पकड़ के लाना पड़ता है, उसकी स्टिक आ जाती है एंड इट इज़ नॉट अ गुड कंडीशन. उसको खांसने के लिए जो एफर्ट लगाना पड़ता है ना, यू एट टाइम्स फील पर्टिकुलर इसको हो क्या है. एंड COPD इज वन सच कंडीशन कि वो 23 साल से डॉक्टर को रेगुलरली दिखा रहा है, फिर भी वो डॉक्टर उसके प्रोग्रेशन को रोक नहीं पा रहा है. उसके दो कारण हैं. वन इज COPD इज लाइक यू नो इट इज़ अ चेन रिएक्शन. वंस इट स्टार्ट्स इट विल कीप ऑन वर्सनिंग. And the very sad reality is tobacco smoking. In COPD, the biggest risk factor is tobacco, apart from smoke. So tobacco causes a lot of negative metabolism, lot of catabolism, lot of pro-inflammatory state to come up. And believe me, जो COPD पर्सन बीड़ी पीते पीते COPD का बना है, वो आखिरी तक भी बीड़ी छोड़ता नहीं है उसकी. मतलब इट्स सो डेंजरस. People actually smoke बीड़ी with oxygen on their nose. They can have a big explosion at every point. But that is the fact of matter. मतलब you deal with COPD, you understand that it is a problem in which the patient is with you, you are trying to treat him, but believe me, without your intervention, it will be very difficult to take care of these patients in a very effective way. So, always the COPD will progress with age. It will progress with the more number of smoking, tobacco products that they use, the less number of medicines that they use. Problem is, on an average, COPD is a disease of, you know, not very elite. It is a disease of people who are in the lower class or lower income group. They predominantly use unregulated tobacco products. So they will spend whatever 100 rupees they have, they will spend 50 rupees on tobacco and hardly 50 rupees on medicines. But what I have come to realize and I have come to convey is, of that 50 rupees of medicines, ma'am, I believe at least 20-25 should go to nutritional aspects. And maybe that is how we can even cut down on their medications more, by concentrating on conditions like sarcopenia. This is very important. I am sorry I am not reading from this thing, but that is what I can share basically. Now, this is a very easy and good slide. See, important thing is age and COPD combined. All of us have been talking in the past few presentations about how things evolve, COPD, inflammation and everything. But important thing is, whenever a COPD person ages, actually the overall efficacy of the lungs as a whole, they decrease. उनकी हवा की नलियाँ जो almost 80-85% खुली रहती थी, they will be hardly 40-50% open. Age contributes, their nature contributes, and this inflammation contributes. So altogether it causes a lot of muscle wasting, and ultimately this decreased protein intake along with the inflammation results in the condition called as sarcopenia. Now the treatment, all of you are much better at treating it than me. I have no मतलब कोई मतलब नहीं है कि मैं अपना ज्ञान झाड़ूं यहाँ पे उस पर. I need to take your help in that, and I have to admit that has to be done on a very important basis. We nowadays I am working in a corporate hospital. I see the problem. जब भी किसी को बोलो भाई उसको दिखाना है तो उसकी त्योरियाँ चढ़ जाती, भाई वहाँ भी OPD कटानी पड़ेगी क्या सर. But the thing is that we need to understand, it is very important. How these things are worked out, we have to work them out. Most major hospitals in places like Bombay are now offering multidisciplinary consultations. Multidisciplinary consultations of diseases like COPD, sleep apnea, lung cancer, asthma. All of this is now becoming more of a multidisciplinary thing. So I feel we need to definitely include you guys more as a partner in our healthcare for the COPD patient. There has to be more oral nutrition supplementation of both micronutrients and proteins in our COPD cases. Nisha ma'am is there, she very well knows pulmonary rehabilitation is a very important aspect. So many patients, see, one COPD patient, the story at the end of it becomes very sad. प्रॉब्लम ये है कि आपको सब लगता है, आपको दवाइयाँ भी लगती है, आपको बार बार डॉक्टर के पास भी जाना पड़ता है, आपको फिजियोथेरेपिस्ट के पास जाके पल्मोनरी रिहैब भी करना पड़ता है, और फिर आपको आपके न्यूट्रिशन के ऊपर भी ध्यान देना पड़ता है. फॉर ऑल ऑफ दिस यू ऑल्सो नीड एन अटेंडेंट टू कम विद यू, एंड बिलीव मी, आउट ऑफ 10 एवरी 5 पेशेंट्स को अपने इस सब में उनके एडिक्शन को भी चालू रखने के लिए उनका रहता है. सो इट्स सो डिफिकल्ट. इमेजिन द लाइफ ऑफ अ COPD पेशेंट, इट्स वेरी टफ. So we should definitely try to intervene. We should optimize protein and energy intake. Definitely, if the COPD patient has an added disease like a CKD or a liver disease, so it is actually very difficult. Very difficult. It is even difficult for me to imagine that situation for the patient. Coming out of the ICU, I would say, is still a time-bound thing. But maybe living with COPD is more difficult. You know, people who come to the OPD, it becomes difficult. बिना wheelchair के they can't even go back downstairs. So looking at them, you can see the need for their muscles to become more strong. Why it develops? Chronic systemic inflammation, oxidative stress and hypoxia. So you have almost 20 to 30% of your COPD patients who will be dependent on oxygen. So they are those group of COPD patients who are severe COPD or very severe COPD. So definitely I feel a strong diet plan is needed for at least those COPD patients who have started needing oxygen therapy. Third is physical inactivity, and fourth is our own folly of not advising them proper nutritional support. That is a big problem. So prognosis, see, COPD is a downhill course. COPD is never an uphill course. If you have an added element of sarcopenia, then the graph becomes more steeper of downhill. So concentrate, somehow try to convince your physician or chest physicians to include you more into the treatment protocol. That has to be done in some way or the other. The management strategies we have already discussed are nutritional support, pulmonary rehab, and targeted exercise. But believe me, they might be looking separate, but they are all a part of each other. If you do physiotherapy without a proper nutritional support, it will actually, you will end up harming the patient. So everything has to be done in tandem, and then only it will come out to have a proper color. So my concluding slide is that COPD is a big problem. COPD कहते हैं कि in another few years will become the #1 cause of mortality all over the world. In that, sarcopenia is a very big problem, and I strongly feel that early diagnosis of sarcopenia by these tests, I would be stressing it upon more to my residents and registrars and including it in my practice. But I have full faith and belief, and I will be referring my COPD patients to you to take care. Thank you.
Thank you so much, sir. It was really an amazing one. For the felicitation of Dr. Ravi Dosi, sir, I would like to call